This is a University of Otago podcast.
Inga mana inga reo, inga tā wira pumanawa, ro rakatira ma, tena koto, tena tato katoa. My name is Harlene Hayne, and I'm the Vice-Chancellor here at the University of Otago, and it is my great pleasure to welcome you to Darryl Tong's inaugural Professorial lecture. I'd like to welcome the staff and students from the University of Otago. I'd also like to welcome members of the University Council and members of the general Dunedin community. But I'd also like to extend a particularly warm welcome to Darryl's family, who are here with us this evening. His wife, Catherine, is here, as well as 3 of their 4 children, Katie, Victoria, and William. Unfortunately, Philip is unable to join us this evening because he is busy pursuing his studies in architecture at Victoria. Well, we have all gathered together here this evening to celebrate Darryl's promotion to professor. Now, I first met Darryl when I was the Deputy Vice-Chancellor here at the University of Otago, and he and his colleague, Neil Waddell, presented their invention to the board of Otago Innovation Limited. Now, at a time when not everyone in the university could see the value in the commercialization of research, Darryl and Neil's life-saving device became the poster child that I used to help people understand not only how universities could commercialize their findings, but why they must. Now, like all professors here at the University of Otago, Darryl is a gifted teacher and a world-class researcher. But tonight, in my opening remarks, I want to focus briefly on his service. In addition to his academic roles, Darryl is also a max fax surgeon here in Dunedin. He is the man who gets hauled out of bed in the middle of the night to save not only a face, but often a life. He has also the unique honor of being the honorary surgeon to His Excellency the Governor-General of New Zealand. Holding the rank of Colonel, Darryl is the only max fax consultant for the New Zealand Defence Force. He was deployed to Afghanistan in 2009, where he was the first New Zealand uniformed surgeon to be deployed to a combat zone since the Vietnam War. Within our university community, Darryl uses his medical talents to provide vital support during our Hyde Street party each year. And throughout the rest of the year, he also has come to the rescue of some of our students in their gravest hour of need. So in short, Darryl Tong is one busy man. He's a teacher, a researcher, an inventor, a surgeon, and an officer. And on top of all this, he is one of the nicest and the most humble people I have ever known. I am very much looking forward to his lecture this evening. So Darryl, on behalf of the University of Otago, I would like to warmly congratulate you on your well-deserved promotion to professor, and I will now call on Professor Paul Brunton, the Dean of the Dental School, to tell us a little bit more about your academic and professional history. Tena koto, tena tato katoa.
Kia ora, tena koto katoa. Darryl is, as we've heard, an oral and maxillofacial surgeon who qualified in dentistry and medicine from the University of Otago and completed his specialist training in Seattle in the States, gaining a master's degree from the University of Washington. Darryl completed his PhD in war surgery of the face and jaws in 2013, and we've already heard was promoted to professor in 2016 here at the University of Otago. He holds fellowships from the Royal Colleges of Surgeons in Ireland and England, and the American College of Surgeons, and is an active clinician, teacher, and researcher. His varied research interests include military and ballistic trauma, military and surgical history, and quantifying the impact forces associated with concussion, subconcussion, involving the development of a forensic head model. In addition to all the things you've heard that Darryl does, he finds time to be both a husband and a father to 4 children, as we know. And in addition to all that, he's a very valued colleague here at the dental school. I now invite Darryl to address us with his lecture entitled Faces of War and Peace. Darryl Tong.
So tonight is very much a night of saying thank you to all these people, these wonderful people that have come into my life to help me get to where I am today. And it's been a journey. And those who have known me for a long time, those who have known me for a long time, it's a rather tortuous journey as well. My family's been in New Zealand for 4 generations. My great-grandfather came just after the gold rush and worked as a common labourer and set up one of the first Chinese laundries in central Otago. Gore, of all places. It's never been the same since. My grandparents' generation worked in the market gardens. My parents' generation worked in the food industry, and that's where I grew up. I was the skinny Asian kid behind the counter taking your dinner orders, right, and saying, "Hey, do you want rice with that?" Anyway, so the first of my thank yous is to thank my ancestral family for putting up with discrimination, deprivation, and just sheer hard work to give us what we have today. I thank my parents for giving me a work ethic which I hold very dear and I'm trying to impart upon others, house surgeons and registrars included. When I was very young, I was brought up by my grandparents. Now, I dearly miss my grandparents. I mean, what's not to like? I mean, how can you not like someone who smokes a pipe, eh? All granddads should smoke a pipe. And Grandma and Granddad made sure that my brother and myself understood the value of getting a good education, because they understood the only way to escape the sheer misery of what they went through is to get a good education. And so I managed to bumble my way through school and high school and college and eventually landed in the mighty Otago University, and that's the School of Dentistry in circa late 1980s. And I know this because, look, there's Pizza Hut. Now, why I say that is because during our time here, late 80s, that's when Pizza Hut first opened. It was magnificent. Foreign food, wonderful. Anyway, so another one of my things. Now, one thing I can't find at all is a faculty photo from the 1980s. It doesn't really matter because I think most of you are still here. So you're to blame for what I am today, so I'm sorry. But thank you, faculty, for teaching me and putting up with me. And also thank you to the nursing staff, some of which are here today as well, and the general clerical staff who are often forgotten when you start thanking to people. But good, solid education. I also like to thank the New Zealand hospital system for not giving me a job as a house surgeon and forcing me to go to Outback Australia, where I learnt self-reliance and, just as important, self-belief. And that's something that, for you younger people coming through, you've got to back yourselves, because what we do at the university, we give you the tools to do this, but you've got to take them and build stuff with them. Now, in my time in Outback, I received a telegram. There's no email back in those days. A telegram, good old-fashioned piece of paper, say, do you want your Rotary Foundation scholarship for a trip overseas for a year to study? I said, wow, do I what? Yeah. So after a bit of homework and discussing with people, I managed to land a spot at the mighty University of Washington in Seattle. This is the Health Sci campus. I mean, look at it. It's the size of Oamaru. I mean, it's massive. I mean, you drive from one place. It's even got its own waterfront. But why don't we have that here? And wow, talk about learning heaps and terrible hours. So, Rahana, hi Rahana, and Harshu's not here today. We trained, and the house surgeons don't believe this, but we trained before the 70-hour cap. So the hours were horrible, so they don't believe the stuff we went through, but anyway. And over half of that time in the 7 years that I spent in Seattle was at Harborview Medical Centre, which is a level 1 trauma centre and the only state-funded hospital in Seattle at the time. And we saw lots of stuff. And talk about busy in terms of just general trauma and ballistic trauma, the military surgeons would rotate through our hospital to get experience. That's how busy it was. I think 3 men in particular, and I think all my teachers, but these 3 men put me on my career path early on. Professor Philip Worthington, Bob Mile, and Ross Byrne. I thank Philip Worthington in teaching me the value of talking and communicating with patients and really connecting with them. I also thank him as a role model for showing me the dignity of our profession. In 7 years that I knew him, he had never raised his voice, and yet anyone and everyone would do things for him. Bob Mile taught me the value of diagnosis and always questioning why. Why is it happening? Are you truly happy with what you've come up with? Is there more that we've missed? Is there more that we can do? And Ross Byrne, who was out here a few years ago as a visiting professor, nurtured me in terms of research and teaching. All 3 of them backed my application when I came back to Otago in 1999. And there you go. And a bit of a culture shock. I mean, Catherine and I came back from a city of close on 5 million and 24-hour convenience to a city of less than 100,000 and shops that were closed on Sundays. So it was a bit of a culture shock. Of course, we love it here now. Just wouldn't think of a better place. What a privilege it is to be an academic staff member at Otago University. And one thing that has been very, very clear and crystallised in the last few years is the importance of the 3 arms of academic practice. It's teaching, service, and research. And as you can see from a 3-legged stool, if one is deficient or even missing, things are very unstable and might even fall over. So that's one thing that we need to embrace, is the fact that we have 3 arms, or in this case 3 legs, but it all works together to prop up your academic practice. In terms of teaching, I have a heavy teaching load, as many of my colleagues, if not all of my colleagues who work at the dental school as well. So I teach many year groups and courses in dentistry, but I also teach medical students and postgraduates, nursing staff, but also teaching roles outside of the university, particularly with St John's Medics, New Zealand Dental Association, and the Defence Force and the Royal Australasian College of Dental Surgeons. So that's a big part of the academic practice. In terms of service, proudly 100% owned by the university, but I do most of my major trauma work and on-call work through the hospital. And I'm very, very honoured to see some of my colleagues from the hospital here tonight. But also out in the community as well. As you know, I'm very involved with the military. Also looking after veterans at Monticello War Veterans Rest Home and Hospital. But also again with St John's, and some mentorship and pastoral care at St Margaret's College Hall of Residence. In terms of research, it's an evolving feast. And these are only just snippets of what I'm currently involved with. And as you can see, lots of names there, and it is a great privilege to be surrounded and supported by like-minded people, some very talented people. And I apologise now, if your name's not up there, I'm sorry. It's not because I don't like you, it's just that I just can't fit everything on. Now, in terms of tonight though, I want to focus on a couple of areas of research. One is the forensic head model in subconcussive injury. The other is war surgery and military history. Because these 2 research areas are wonderful in terms of how things actually come together in terms of research, teaching and service. Now you're thinking, well, how does this actually work? Well, if you change those words around, when you talk about research, you're talking about evidence-based medicine. If you're talking about teaching, it's the transfer of knowledge and the transfer of how to be a professional. And in terms of service, it's clinical and professional experience. You can't teach without experience. You can't teach without knowing what your students need to know yourself. You can't research without having a question. So these things fit together. And at this stage, I want to say a very, very big thank you to the wonderful surgical firm of De Silva De Tong. I have never worked in a place where the surgical colleagues treat each other like brothers. So thank you, Rohana. I mean, we really look after each other. I mean, it's the only place I know of that we actually fight to take call off each other. What are you talking? No, that's, it's a dumb thing to do. But anyway, we do this and we support each other, and it's a wonderful thing. So thank you. And I'm sure Harsh is not even paying attention somewhere. Anyway, because he's in Sri Lanka. Right, facial trauma in war and peace. A few years ago, our late Professor Jules Keyser, myself and a few others looked at some facial trauma statistics over a 20-year period. And what we found was not really surprising, but it was interesting at the time to actually put it on paper, that there was a fair amount of trauma being seen, predominantly male, and the age groups involved, namely young people. The main causes that we found for males was interpersonal violence, or BIFO, sports-related injuries, and motor vehicle accidents. Now, this is different from places like the Middle East. The reason being, as you soon find out, is probably alcohol. And the pattern of interpersonal violence, followed by sports, followed by MVAs, is similar in Australia and similar in Glasgow, of all places, not surprising at all, and also South Africa as well, but not the States, and certainly not in the Middle East, and certainly not parts of Malaysia. Main causes of females: unintentional falls, followed by interpersonal violence, followed by motor vehicle accidents. Now, you're scratching your head. So who would intentionally fall? No one would say, I'm going to wake up today, I'm going to fall over. Unfortunately, there is a sinister side to this. Unintentional fall is code word for domestic violence. How did you get your black eye? I fell over. Or how many times did you fall over to get the facial injuries that you got? And it's sad that New Zealand, such a wonderful, clean, green country, has some of the worst records of interpersonal violence, domestic violence in the world. And it's up to us, as health professionals, as a community, to stop that. No, I'm not going to go down that road because I'll probably get in trouble, so I won't. I'll tell you afterwards. Anyway, so a few years later, we decided, let's see what's happening. Have we improved all these messages of don't hit people, wear mouth guards, that type of thing? Guess what? Nothing's really changed. But what has changed is the consumption of alcohol, the lowering of the legal drinking age, the sheer availability in supermarkets. I mean, it shocks me that I can go into a well-known supermarket chain. You walk in through their barriers, and the first thing you see, apart from your fruit and veg, alcohol. It's just there in your face, and big, bold marketing things, on sale now. Brain cell death, in a bottle, and it's binge drinking. In those ads, it's not what we drink, it's how we drink. And going on about the Hyde Street Keg Party a couple of years ago, 99% of the people we saw were young women. Not just a little bit drunk, paralytically drunk. Like, what's gone on? It's weird. The good news, especially with pediatric stuff, pediatric facial trauma has decreased over time, and also motor vehicle accident related trauma has gone down over time as well. This is probably due to compulsory seatbelt wearing, wider public education and other bits and pieces there. However, alcohol still remains the single most potent cause of injuries when it comes to facial fractures or facial injuries. So, what are the general trends? Studies show that young people are overrepresented, especially young males, but young females are catching up, and that's disturbing. Alcohol, it's the amount, how you drink, and the whole culture behind it of let's get seriously drunk. It's not let's drink and have a good time, it's let's get seriously drunk. And unfortunately, and there's no evidence for this, I'm sorry, but anecdotally, the level of interpersonal violence is getting worse. It's vicious and it's targeted. When I was growing up as a kid in school, if you want to pick a fight with someone, you don't hit in the face and you don't hit in the private bits because that's cowardly. Now people really go for you, and while you're down, they'll boot you and stamp on you. When has that become acceptable? Don't know. Is it any different in warfare? Well, I think you're a bit more worried than the odd boot when you're being fired upon in warfare. But maxillofacial injuries have certainly become more, excuse the pun, in your face. All right? It's number 2 in terms of the injuries seen in combat-related casualties. The number 1 being orthopedic or limb injuries. And you're talking about significant multi-system trauma, not just the face, but you're now looking at people like this young man, 3 limbs missing. I remember one patient when I was in Kandahar, 3 limb injuries, 2 legs, 1 arm, partially severed, facial injuries, chest injuries, abdominal injuries. 1 person. The good news is that if you reached the Roll 3 multinational medical centre, you had a 97% chance of survival. But you have to ask yourself, at what cost? This is the human cost of war. The current incidence, if you look at the UK and US data from Afghanistan and Iraq, is around about the 18 to 26%. Israeli figures, if you include the West Bank, Gaza and Lebanon, it can be up to 54% of combat-related casualties. However, when you look at this is significantly different from warfare in the past, where if you average out, Dobson et al. In 1989 looked at 13 major conflicts over time, and the overall incidence of head, face, and neck injuries was only 16%. Unusually, World War II was only 4%, and their reasoning behind that, they thought, was mainly because of mobile warfare more than anything else. So why is there an increase in combat-related head, face, and neck injuries? Is it because people are actually targeting the face? There are 2 studies that show maybe. One is an Indian study when they looked at special forces in the Swat Valley. The other study was from 1993 from Mogadishu. So the movie Black Hawk Down, that incident. The main issue there, you had people firing down from rooftops. And so when the soldiers were looking up, head, face, and neck injuries. There's no evidence that combat body armour increases your risk. Because that was one of the questions. Is it just the fact that you're wearing body armour? So Ross Byrne and myself did a systematic review. You can't do randomized controlled trials for combat body armour. So we've discovered, you wear a pillow, you go out there and see what happens. All right? Doesn't quite happen. That's not good military tactics. What we found is that it was the survivability of the combat soldier. Current body armour is so good that no rounds will penetrate it. That's been evidenced since Mogadishu from 1993. It stops bullets. And so what used to be lethal torso injuries doesn't matter if you've got facial injuries if you're dead, because we're not going to fix it. So these soldiers are coming in surviving with horrendous injuries. There's the vulnerability of exposed areas. Combat body armour is very good, but you can't encase yourself in it because there's mobility, there's communication issues with that. So that from a tactical environment, you need to be able to move, you need to be able to hear and see and talk to each other. So there's that age-old chestnut of protection versus mobility. But probably what's the biggest thing about modern combat, so-called asymmetric warfare, is this mechanism of injury. It's no longer gunshot wounds, it's fragment injury. And it's not artillery shells, not like World War I. We're talking about improvised explosive devices, linking landmines together with a 155 millimeter howitzer shell. I mean, serious firepower and serious fragment dispersion. So blast injuries, fragments, and then to a lesser extent gunshot wounds. But the key thing is soldiers are surviving in order to get fixed. And so when you have injuries like this, there's nothing red on this, it'll be fine. When you have injuries like, where do you start? Where do you start? You know what it's like having a pocket watch. You know what it's supposed to look like, and you got the bits, but how do you actually put it together? And we're very lucky now that we have some idea, some sort of guidebook. Look it up on the internet sometimes. Oh, that's how you do it. YouTube's probably got stuff like this. But back in the day, these two men did not have YouTube or reference text, or even Uncle Rahana. These guys aren't going to call him, Rahana, what I do. They're going to say, well, this is what we've got, and gosh, we'll make the most of it. So Harold Gillies, who most of you should be aware of, born in Dunedin, 44 Park Street at the moment. His house is up for sale, apparently. If you have a spare $3.5 million, there you go. Harold Gillies was born here, father of modern plastic surgery. Prior to World War I, plastic surgery was not a specialty. It was not even recognised as any field of surgery as such. William Kelsey Fry is probably the prototype of what we are as an oral and maxillofacial surgeons. He's a dental officer, medically qualified, and he said to Harold Gillies, look, I'll do all the hard tissue stuff, you do all the soft tissue stuff. And so what a wonderful partnership that became. Dunedin is forever linked with the pioneering days of plastic and maxillofacial surgery. So here's an older Harold Gillies. Here we have Percy Pickerel, first dean of the dental school, first plastic surgeon in Australasia, coming back from the war. And Archie McIndoe, you can tell he's an Otago graduate. He's got a beer in his hand, brilliant. And Rainsford Mallam, probably the least known of the four pioneer surgeons from Dunedin, but from a clinical standpoint, really important, because he talked about corticocancellous chip grafting. So it's having a big block of bone. If you chip it all up, you actually get a much better and faster healing period. He discovered and wrote that up 1944. Now that's not yesterday. Anyway, so a huge link for plastic and maxillofacial surgeries. This is the stuff that Gillies had to contend with. This is 1914, 1915, prior to antibiotics, right? What were they using for skin sutures? Horsehair. What were they using for deep structures? Catgut, carbolized catgut. So you're talking about primitive stuff and no textbooks, no idea. So it's very much art, innovation, and I got nothing else except my hands and what I'm thinking of. What's the next step? I don't know. And sure, they made mistakes. And it's those mistakes that have become principles, which is now not so much, it's not the mistakes themselves, obviously, but it's the prevention of those mistakes that we, modern surgeons, now have as our dogma, as our teaching. And it's some pretty amazing stuff, really, when you think of it. I mean, this, even today, is a very challenging reconstruction. Now, you're wondering why he's got this pencil on his head. That's actually a piece of cartilage buried underneath his scalp to keep it alive. They've got nowhere else to put it, so you put it underneath his head. And then swinging the pedicle flap, for which Gillies is famous for, you reconstruct the nose, and over time, debulking the nose. And, okay, not perfect, but this is very acceptable. You can walk down the street, get married, have a beer looking like this. Or at least have a beer, all right? Okay. Percy Pickrell, of course, being dentally as well as medically qualified, and being the dean of the dental school, had a much wider view, in my experience, of facial reconstruction, because now we're talking about someone who understands occlusion, how teeth actually fit together. Wow, mind-blowing, eh? Absolutely. And he commissioned some wax artworks, mainly for teaching, but also as a reminder of the carnage of war. Now, these two models, wax models, are currently in the Dominion, National War Museum up in Wellington on loan. And it's been acknowledged, it's from the University of Otago in the School of Dentistry. But these are works of art in its own right. I mean, those of you who are familiar with the anatomy, I mean, that's buccal fat pad, made in wax and painted up. Now, this is seriously art form, mate. This is really good. A case illustration. This is a young man shot through the cheek and then blasted with fragment injury on death's door. Reached New Zealand, the New Zealand unit, nursed back to health, but just wasn't doing well in terms of facial fractures. And not surprising, because that's his jaw relationship. So basically, his entire mid-face is retruded a good, good inch. Yeah, that's not, for those non-dental, that's not how you bite, all right? So that top jaw is totally retruded back. Now, think orthopedic, think orthodontic, and think occlusion. Now, wow, what a concept, all these different things going on. So why don't you use traction to wind these facial fractures back out and use the teeth as guides? And so over time, you're winding out these jack screws, pulling the fractured bones out. And this is 2 years later. And again, very acceptable. Obviously, he's had a nose job and the scar on his face has been revised. The spine tingling thing is we have this in the dental school archives. And it's the same person, you can tell, scar on the cheek. The sheer workmanship. I mean, this is all custom made, hand soldered. It's mind-blowing. Does this look familiar? You bet. We're still using that concept for craniofacial distraction osteogenesis, for craniofacial anomalies. So same concept. Brilliant. Of course, when we have panfacial fractures, we have the luxury of titanium now in all its various guises. We don't have to rely on dental appliances and traction. But guess what? We can still always go back to that because that is our fallback option. The reason why we can, because it works. Don't reinvent the wheel. So even though 100 years on, we have better devices, better equipment, more resources, that's irrelevant. What drives us today is actually the principles that were founded by Gillies and other pioneering surgeons that we sometimes take for granted. And it's sad in some ways that in speaking to trainees, do you know why this is called the Gillies technique? They have no clue. Who is Gillies? And you want to strangle them because you don't know about Gillies. All right, set of principles. See you later. Anyway, set of principles. It's those principles that still guide us. And guess what? 100 years on, we are still using these principles. For example, mandibular fracture management, or actually just fracture management in general, but this is particular to mandibles. Reduce bony fragments, fix them, hold them in place, make sure that your anatomical spaces are correct so that when you rebuild stuff, you're not putting things that don't fit into a small space. 1916, we're still doing that today. Stuff from Afghanistan, guess what? Why are we still doing this type of free pedicle graft, rebuilding noses? Because it works. And especially in places like Iraq and Afghanistan, or it could be any other place that you don't have a lot of resources, you stick to basic stuff that works. This has got a blood supply. This has got to survive. Okay? What have we learned from war? We talk about the golden hour. Guess what? We're now talking about the platinum 15 minutes. Right? In civilian trauma, it's airway, breathing, circulation, disability, exposure. But top three, airway, breathing, circulation. If you can't breathe, nothing else matters. Easy. In a combat situation, it's march, it's massive hemorrhage control, then airway, because people will bleed out their lifeblood from their injuries. They don't close off their airways or choke, they bleed to death. So slight difference in how you manage trauma initially, but platinum 15 minutes. Damage control, resuscitation and surgery. How am I doing for time? Yeah, almost there, right? Yeah. Blood replacement therapy. We think we're reinventing the wheel. The Canadians talked about this in World War I. So it's nothing real different. It's just a revisitation of these things. So this is a good example of how clinical aspects, knowledge and evidence come together, but also how war, as the greatest school of surgery, affects civilian trauma. But sometimes, especially if you're working in an academic institution, you can use your civilian skills in a war environment. This is a young 18-month-old boy with 2nd and 3rd degree burns to face and scalp. He is being fed pure cream to give him nutritional status, nutritional value, trying to bulk him up. There's not much you can do with that. And that's the scary thing about it. If you don't skin graft this kid, he's going to get infected and he will die. However, this is down to bone. This is leather down to bone. If you take that off, you cannot skin graft on bone. He will get infected and he will die. This is an 18-month-old civilian casualty. If there was a massive push and we got military casualties coming out of our ears, he would have been the first person to get out of our combat hospital, shunted to the local hospital where he would get infected and die. So these are things that people don't talk about in the media. They don't talk about the feelings of, I'm hanging on to this kid for dear life because his life depends on it. These are the decisions that we make in a combat hospital. So every 2 days, we'll take him, debride all the scar tissue, and then wonderful stuff. Don, you'll be familiar with this, nanoparticles, silver particles, wonderful, antibacterial stuff. $100 a sheet. They didn't care about prices. Hey, you want some? Have some. Magnificent. And we'll dress them, and now the crunch time. What do we do with this? And this was a nervous time. The whole combat hospital was buzzing over this. We took the plunge. We took it off, and this is bare bone. Now, civilian stuff. What do we do with dental implants? Guess what? When you take a piece of bone, you drill holes in it, and then you bonk it somewhere else inside the jaw. Why do you drill holes in it? Because it releases growth factors, promotes healing, and promotes granulation tissue. So I said to the surgeon, hey, you know what? I'm going to drill holes in this kid's head. And the entire front row has the same look as my surgeon colleagues. Like, you what? And that's exactly what we did. We drilled holes in his head. Not right through. You don't drill it right through. No. Just the top of it. 10 days later, look at that. Soft gold. And we were able to skin graft this. Our anaesthetist, who is a Danish anaesthetist, 63 years old at that stage, deployed 15 times. We nicknamed him the grumpy old man. And he said in his very Danish way, you know, this is very special. And we thought it was pretty special as well, and we wrote it up. 2 weeks later, and that was my goodbye present. So that's kind of neat. Okay, subconcussion. Hey, who would have thought that cheerleading was a dangerous sport? But it is, as you do when you face plant. It's a silent epidemic. People talk about it, try and ignore it, but it is a silent epidemic. 2006, almost 4 million people in the US alone had some sort of concussive injury. It's not well understood, and especially subconcussion is not well understood or quantified. What does it mean for young people? Will it affect young brains later on, leading to chronic traumatic encephalopathy? So, one area of research, let's quantify this. Let's use our biomaterials, biomechanical expertise at the dental school. Let's try and capture this data. As you know, I like doing kendo. I like hitting people with bamboo sticks. And in kendo, head strikes are good. And it's permitted. So, rigging up stuff. This is an impact sensor, a trigger, and T1, T2 lasers. It's a fixed distance, and that will give you your velocity. And so that will give you your velocity and the impact you get. What we found when we use different conditions, hitting the sensor is similar to hitting bare bone. Then we put a silicon layer, mimicking scalp, and then we put the protective layer. And guess what? Peak impact value went down, but the energy that it absorbed went up. What does that mean in terms of what's going through into your brains? Now, I thank Lisa Falland for these photos. And this is the research group that Neil and I are working on at the moment. And now the next step up from this is let's build a forensic head model that we can use and beat instead of beating each other up. It's very tempting. Okay, so prototype model assembly, there's a lot of work here and some really amazing preliminary data. There is a kind of a Newton's cradle phenomenon here. And part of that is some teething issues with the actual model itself. But what you can see here is that at varying levels we can detect force transmission, and we're trying to work and perfect that at the moment. The next step from here is to actually build an anatomical head. It can never be the same as a real one, but gee whiz, this is getting kind of up there. What are the future research implications? Well, anatomical models for forensic for forensic research, as military and sports implications. And so, ladies and gentlemen, teaching, service, and research go hand in hand. And especially when you can put it together with clinical applications, it's very powerful. They drive each other. So what's the bottom line? Learn from the past. That's a good time, thank you. Practice in the present and teach for the future. I want to take this time to thank two very dear friends who are unfortunately no longer with us. Phil Cox, a well-known oral and maxillofacial surgeon in Dunedin. He was my mentor and life coach when I came back to Dunedin. Never ever go running with him, all right? Just don't. It's like trying to keep up with a Ferrari. It just doesn't work, eh? I owe him a lot in growing up as a person. Also, Jules Keyser, who was my mentor in academics and research. And the day before he got tragically, he died tragically in an accident, he said, "D, your year next year." Thanks, Jules. All right. And where would I be without my family? Why is it all the photos on Facebook where I'm feeding? I don't know. Thank you. Yeah. And I just want to take this time to thank my wife in particular. Yeah, I've ruined it for you, husbands. Thank you, darling. And thank you.
Thank you, Darryl, for your wonderful presentation. That was great. It gave us insight into the breadth of your clinical and research activities and showed us how the work that you've done relating to war surgery and military medicine has blended with your current research interests in subconcussive and concussive injuries, your current clinical activities, and particularly your undergraduate and postgraduate teaching and how you brought that all together. It was great to be reminded of the immense contribution that our forebears such as Gillies and Pickrell have made and how that work that they've done has been passed on to our current clinicians and all of us in the population at large benefit from that. So thank you, Darryl, very much for the review of those activities and for also telling us something of your personal journey to get there with the help of your proud and very supportive family. So I would like, on behalf of us all, to give you a token of our appreciation. There is a couple of things. I just have to scratch through here for an envelope. And this, so Darryl, all the very best.
Thank you, Alison. Pour Marie, my name is Peter Crampton. I'm the Pro-Vice-Chancellor of Health Sciences, and it's my pleasure and my duty to wrap up this evening. I would like to say thank you to Darryl as well. That was an absolutely tremendous presentation. Thank you so much. And I would also like to give my special greetings to your family and Catherine. I have one, if you will indulge me, one little anecdote which really just reminds me of when I first became aware of Otago's unique history in terms of maxillofacial surgery and also plastic surgery. Prior to coming to Dunedin 5.5 years ago, I was Dean of the University of Otago Wellington campus. And one day I was chatting away to the chief librarian in her office, and I was leaning up against the bookshelf. And I turned around and glanced at the bookshelf, and it was covered with these wooden boxes so big. And I asked her what they were. They looked old. And she said, well, have a look inside. So I took one and slid the lid open. and it was full of glass lantern slides about that size. And she said, now look at what they show. And they were in a series of 2 or 3 or 4 slides together, and each one showed a series of pictures of young men with horribly mutilated faces before, during, and after surgery. And this is the Pickerel collection, sitting there in her office. And I was somewhat taken aback. And Darryl, I don't know where that is now. Where is that collection?
It's the Hocken Library, and there's Anna. Hi, Anna. And, it's Hocken Library are the proud carers of that name. And I'll take this opportunity to plug a website that with the University of Otago archives for face and wall surgery is now live. I can't remember what the website is. But thanks to Anna and the crew at Hocken and also Research and Enterprise for actually for helping get this up and running. So we can all share in this heritage.
No, well, look, thank you. I'm so pleased that they're in the right place now. This exceptional collection of slides showing the very birth of plastic surgery and oral maxillofacial surgery right there. So that was my first introduction to this area, and since then I've had many chats to Darryl about that history and the very unique history which is linked to the University of Otago. So thank you again, Darryl, and I'd like to thank everybody here. Thank you to Darryl's family in particular. Thank you to friends and colleagues and members of the public for being present tonight and supporting Darryl in his inaugural professorial lecture. Finally, I would like to invite everybody to refreshments. We go out of this building, up around the building works and across to the staff club, and I look forward to continuing our conversations there. Thank you very much.